Good morning. Now, today in infectious diseases, we are discussing typhoid fever or enteric fever. Typhoid fever is basically a bacterial disease which is caused by bacteria, that is Salmonella typhi. It is a systemic infection. Salmonella typhi infection is found only in man. The disease is clinically characterized by typical continuous fever for 2 to 3 weeks with relative bradycardia with involvement of lymphoid tissue and considerable constitutional symptoms. The term enteric fever includes both typhoid as well as paratyphoid fever. Typhoid fever is caused by Salmonella typhi, whereas paratyphoid fever is caused by Salmonella paratyphi. The disease may occur sporadically, epidemically, or endemically. Epidemiological determinants: agent is Salmonella typhi is the major cause of enteric fever. S. paratyphi A and S. paratyphi B, they are relatively infrequent. This is the structure of typhoid bacillus. This is bacillus, and you can see the flagella as well as the structure which is rod shaped, and fimbriae around the wall of the bacteria. Bacteriologically, typhoid fever, the genus Salmonella belongs to Enterobacteriaceae family. They are facultative anaerobes, gram-negative type of bacillus, distinguished from other bacteria by biochemical and antigenic structure. S. typhi has three main antigens: the O antigen, the H antigen, and V, and a number of phase types. S. typhi survives intracellularly in the tissue of various organs. It is readily killed by drying, pasteurization, and common disinfectants. The factor which influences the onset of typhoid fever in man are the infecting dose and virulence of the organism. Reservoir of infection: man is the only known reservoir of the infection, in which two types, one is the cases and another one is the carrier. These are the reservoir for Salmonella typhi. A case is infectious as long as bacilli appears in stool or urine. Now, the carriers may be temporary or chronic. Temporary means incubatory convalescent, or chronic. Convalescent carrier excretes bacilli for 6 to 8 weeks, after which their number diminishes rapidly by the end of 3 months. And the person who excretes bacilli for more than 1 year or after clinical attack are called as chronic carriers. For years together, if the person is excreting the bacilli, they are chronic carrier. In most chronic carrier, the bacilli exist in gallbladder and the biliary tract. It is the choice of stay of this bacteria in the human body is gallbladder and biliary tract. Mostly they resides at these sites. A chronic carrier may excrete the bacilli for several years, maybe as long as 50 years. A famous case of typhoid Mary who gave rise to 1300 cases in her lifetime is an example for a chronic carrier state. Fecal carriers are more common than urinary carriers. This is the picture of typhoid Mary. Now, source of infection. The primary sources of infection are feces and urine of cases or carriers. The secondary sources includes contaminated water, food, finger and flies. Host factors. Age. Typhoid fever may occur at any age. Age is no criteria, it occurs at any age. Gender. Males are more frequently affected than females. Immunity. All ages are susceptible to infection. The host factors that contributes to resistance to the bacilli are gastric acidity and local intestinal immunity. Environmental and social factors. Enteric fever are observed throughout the year. The peak incidence is reported during July to September. Vegetable grown in sewage farmlands or washed in contaminated water are positive health hazards. They can cause the spread of infection. Typhoid bacilli grow rapidly in milk without altering in taste or appearance in any way, in which case ingestion of such raw milk possesses to threat to the consumer. These factors are compounded by such social factors as pollution of drinking water supply, open air defecation and urination, low standards of food and personal hygiene, and health ignorance, obviously. Therefore, typhoid fever may be regarded as an index of general sanitation in any country. Where there is poor hygiene, poor sanitation, defecation in open grounds, urination in open grounds, these are all the factors which, if the country is having poor sanitation, then the spread of typhoid fever is more. Incubation period. As far as incubation period is concerned, it is usually 10 to 14 days, but it can be as short as 3 days or as long as 3 weeks, depending on the dose of bacilli ingested. Mode of transmission. Typhoid fever is transmitted via the feco-oral route or urine-oral routes. This may take place directly through soiled hands contaminated with feces or urine of cases or carriers, or indirectly by the ingestion of contaminated water, milk, food, or through flies. This is the diagram showing modes of transmission, that is the dynamics of transmission. Feces and urine from cases of carriers, through water, through soil, through flies, through fingers, through food or raw cooked food, mouth of a well person. Now, clinical features. Now, as far as clinical features are concerned, the onset is insidious, but in children may be abrupt with chills and high fever. During the prodromal stage, there is malaise, headache, cough, and sore throat, often with abdominal pain and constipation. These are the prodromal symptoms associated with typhoid fever, that is malaise, headache, cough, sore throat, often with abdominal pain and constipation. The fever ascends in step ladder fashion. After about 7 to 10 days, the fever reaches a plateau and the patient looks toxic, appearing exhausted and often prostrated. There may be marked constipation, especially in the early stages, or there may be a pea soup diarrhea. Typically, pea soup diarrhea that occurs in typhoid fever. There is marked abdominal distension. There is leukopenia and blood, urine and stool cultures are positive for salmonella. The leukocyte count will go down. If there are no complications, the patient's condition improves over 7 to 10 days. However, relapse may occur for up to 2 weeks after termination of therapy. During early phase, physical findings are very few. Later, splenomegaly, abdominal distension and tenderness, relative bradycardia, dicrotic pulse and occasionally meningitis is appear. The rash or rose spot that is commonly appear during second week of the disease. The individual spot found as far as clinical features are concerned, the onset is insidious, but in children may be abrupt with chills and high fever. During the prodromal stage, that is the disease prodrome symptoms, there is malaise, headache, cough and sore throat, often with abdominal pain and constipation. The fever ascends in step ladder fashion. After about 7 to 10 days, the fever reaches a plateau and the patient looks toxic, appearing exhausted and often prostrated. There may be marked constipation, especially in early stages, or there may be a diarrhea that is called as pea soup diarrhea. There is marked abdominal distension. There is leukopenia, that is the WBC count goes down, leukocyte count goes down, and blood and urine culture are positive for salmonella. If there are no complications, the patient's condition improves over 7 to 10 days. However, relapse may occur for up to 2 weeks after termination of therapy. During early phase, physical findings are few. In later stages, splenomegaly, abdominal distension, tenderness, relative bradycardia, dicrotic pulse, and occasionally meningitis appears. The rash or rose spot commonly appears during second week of the disease. The individual spot found principally on the trunk, it is pink papule, it is a papular rash It is a pink papule 2 to 3 mm in diameter that fades on pressure, that is, blenches on pressure. It disappears in 3 to 5 days. This is the picture showing rose spots on the trunk and the beak. Serious complications occurs in up to 10% of patients, especially those who have been ill for longer than 2 weeks and who have not received proper treatment. Intestinal hemorrhage is manifested by a sudden drop in temperature and signs of shock, followed by dark or fresh blood in the stool. Intestinal perforation is most likely to occur during the third week. Less frequent complications are urinary retention, pneumonitis, thrombophlebitis, myocarditis, psychosis, cholecystitis, nephritis, and osteomyelitis. As far as laboratory diagnosis is concerned, microbiological procedures, the definitive diagnosis of typhoid fever depends on the isolation of the bacilli from blood, bone marrow, and stools. Blood culture is the mainstay of diagnosis of this disease. Serological procedure. Felix Vidal test measures agglutinating antibody level against O and H antigens. Usually O antibodies appear on the day 6th to 8th and H antibodies on the day 10th to 12th after the onset of the disease. The test is usually performed on an acute serum, the first contact with the patient. The test has moderate sensitivity and specificity. It can be negative up to 30% of the culture, proven cases of typhoid fever. This may be because of prior antibiotic therapy that has blunted the antibody response. Now, new diagnostic test. The ideal Tubex test can detect specific IgM antibodies in samples to Salmonella typhi, liposaccharides, that is LPS antigen, and the staining of bound antibodies by anti-human IgM antibody conjugated to colloidal dye particles. This is showing diagnosis of enteric fever, this feces culture, Vidal test, urine culture, blood culture in weeks. Now, control of typhoid fever. The control or elimination of the typhoid fever is well within the scope of modern public health. There are generally 3 lines of defense against typhoid fever. First one is control of reservoir, second one is control of sanitation, third one is immunization. First one is control of reservoir. The usual methods of control of reservoir are their identification, isolation, treatment, and disinfection. This is the control of reservoir. Early diagnosis. This is of vital importance as the early symptoms are non-specific. Culture of blood and stools are important investigations in the diagnosis of cases. Notification must be done in areas where it is mandatory. Isolation. Since typhoid is an infectious disease, the cases are to be transferred to the hospital. As a rule, cases should be isolated till 3 bacteriological negative stool and urine culture reports are obtained on their 3 separate days. Now, as far as treatment part is concerned, fluoroquinolones are widely regarded as the drug of choice for the treatment of typhoid fever. This is the chart showing treatment strategies. Antibiotics, fluoroquinolones, that is ciprofloxacin, orally 500 mg BID or IV 400 mg BID for 5 to 7 days, oral 5 to 10 mg per kg body weight or IV 4 to 7 mg per kg body weight BID. Ofloxacin orally and IV 400 mg BID for 5 to 7 days. Ceftriaxone IV 2 to 3 mg OD 2 to 3 grams OD for 7 to 14 days. IV 25 to 50 mg per kg body weight OD. Azithromycin orally 1 gram day 1 and 500 OD for 7 to 14 days. Chloramphenicol orally 2 to 3 grams in 4 divided doses for 14 to 21 days. Severe typhoid, this was for uncomplicated typhoid. Now for severe typhoid, ciprofloxacin IV 400 mg BID for 10 to 14 days and orally 5 to 10 mg per kg body weight BID or IV 4 to 7 mg BID. Ceftriaxone IV 2 to 3 grams, that is 60 mg per kg body weight daily for 10 to 14 days. IV 50 mg per kg body weight OD. Cefotaxime IV 2 grams TDS for 10 to 14 days. IV 25 to 50 mg per kg OD. This is the treatment for severe cases. They are relatively inexpensive and well tolerated and more reliable and effective than chloramphenicol, ampicillin, amoxicillin, trimethoprim and sulfamethoxazole. Patients seriously ill and profoundly toxic should be given injection of hydrocortisone in the dose of 100 mg daily for 3 to 4 days. Disinfections, stools and urine are the sole sources of infection. They should be received in a closed container and disinfected with 5% cresol for at least 2 hours. All soiled cloths and linens should be soaked in a solution of 2% chlorine and be stream sterilized. Doctors and nurses should disinfect their hands. In follow-up, examination of stools and urine should be done for Salmonella typhi 3 to 4 months after discharge and again 12 months to prevent development of carrier state. Carriers, since carriers are the ultimate source of infection, their identification and treatment is one of the most radical ways of controlling typhoid fever. The following are the major recommended. Identification. Carriers are identified by cultural and serological examinations. Duodenal drainage establishes the presence of salmonella in the biliary tract of carriers. The antibodies are present in about 80% of chronic carriers. Treatment of carriers. The carriers should be given an intensive course of ampicillin or amoxicillin, that is in the dose of 4 to 6 grams a day, together with probenecid 2 gram per day for 6 weeks. Treatment of carriers: amoxicillin or ampicillin 100 milligram per kg, body weight, duration 6 weeks. TMP SMZ 160 to 800 milligram twice a day, ciprofloxacin 750 milligram twice a day, norfloxacin 400 milligram twice a day. Surgery: cholecystectomy with concomitant ampicillin therapy has been regarded as the most successful approach to the treatment of carriers. Health education. Health education regarding washing of hands with soap after defecation or urination and before preparing food is an essential element. In short, the management of carriers continues to be an unsolved problem. This is the crux of the problem in the elimination of typhoid. Surgery: cholecystectomy with concomitant ampicillin therapy has been regarded as the most successful approach to the treatment of carriers. Health, health education. Health education regarding washing of hands with soap after defecation or urination and before preparing food is an essential element for the prevention of the disease to spread the infection. In short, the management of carriers continues to be an unsolved problem. This is the crux of the problem in the elimination of typhoid. Control of sanitation, protection and purification of drinking water supplies, improvement of basic sanitation, and promotion of food hygiene are essential measures to interrupt transmission of typhoid fever. Now, as far as immunization is concerned, immunization is a complementary approach to the prevention of typhoid. It yields the highest benefit to the money spent. Immunization against typhoid does not give 100% protection, but it definitely lowers both the incidence and seriousness of the infection. It can be given at any age upwards 2 years. Immunization is recommended to those sorry, who live in endemic areas, household contacts, and groups at risk of infection, such as school children and hospital staff, travelers proceeding to endemic areas, and those attending melas and yatras. So, these peoples are at risk always, so they should be immunized. Anti-typhoid vaccines. Two vaccines are available. First one is V polysaccharide vaccine and second one is type 21A vaccine. This is the picture of Typhi M, that is V antigen type of vaccine. V polysaccharide vaccine. The vaccine is composed of purified V capsular polysaccharide form from the Typhi 2S Typhi strain and elicits a T cell independent IgG response that is not boosted by additional doses. The vaccine is administered subcutaneously or intramuscularly. The target level value of each single human dose is about 25 micrograms of antigen. The vaccine is stable for 6 months at 37 degree centigrade and for 2 years at 22 degree centigrade. The recommended storage temperature is 2 to 8 degree centigrade. The V vaccine does not elicit adequate immune response in children aged less than 2 years. Only one dose is required and the vaccine confers protection after 7 days of vaccination. To maintain protection, revaccination is recommended every 3 years. The vaccine can be co-administered with other vaccines such as yellow fever and hepatitis A and with routine childhood vaccinations. No serious adverse events and minimum of local effects are associated with V vaccination. There are no contraindications to the vaccine other than previous hypersensitivity reaction to the vaccine components. If any hypersensitivity in previous dose occurs, then the only contraindication occurs. The Typhoid 21A vaccine is an orally administered live attenuated TY2 strain of Salmonella typhi. The lyophilized vaccine is available as enteric coated capsules. This is the picture of type 21A vaccine. The vaccine has to be stored at 2 to 8 degrees centigrade. It remains potency for approximately 14 days at 25 degrees centigrade. The capsules are licensed for use in individual aged above 5 years. The vaccine is administered every other day on third and fifth day. A third dose regime is recommended. Protective immunity is achieved 7 days after the last dose. The recommendations is to repeat the series every 3 years for people living in endemic areas and every years for individual traveling from non-endemic to endemic areas. Who travels from non-endemic to endemic area, recommendations of vaccines should be 1 year. Facts about typhoid fever. First one is globally, typhoid causes estimated 21 million cases and 2 lakhs deaths every year. Typhoid comas from bacterium called Salmonella typhi. 3 and 4th, 5th, these are the facts. The disease may spread through contaminated food, water and through contacts with an infected individuals. 4th one is an estimated 70% of the people infected from typhoid come from international traveling. About 3 to 5%